Hi, welcome back to this educational video series on how you can incorporate yoga techniques within your hand therapy practice. My name is Bianca, the OT Yogi. Right behind me is Luma, the Corgi. She may make her appearance here and there throughout this educational video series. So today we'll go into the self-efficacy theory, which may help provide guidance in addressing psychosocial factors in clients with upper extremity injuries and disorders, such as diminished self-efficacy, impacting participation in therapy with therapeutic activities, as well as at home with home exercise plans. So according to Picha and Howell, a significant barrier to patient rehabilitation or exercise adherence, particularly for home exercise programs, is low self-efficacy. The model presented here aims to guide clinicians in their practice to improve patient adherence, and once an occupational therapist identifies low self-efficacy, which can be evaluated through a questionnaire specific to self-efficacy for home exercises or a scale measuring confidence in tasks such as the quick dash used to assess self-perceived disability related to specific occupations, this can help identify those needing alternative interventions. So this model, as you can see here, includes 4 core experiences. The first being mastery of experience, which involves a client's first-hand encounters with meaningful activities and focuses on the successful completion of tasks. Clients should master specific exercises that can be continuously built upon once successfully completed. Then the next one, vicarious experiences, occurs when clients observe others overcoming similar challenges and they're able to mimic what they see. Verbal persuasion involves providing feedback throughout exercise sessions to increase self-efficacy. And the last one, physiological emotional states relate to that feedback that patients receive, such as increased heart rate or perceived exertion, which can also affect self-efficacy. So to summarize, this framework offers occupational therapists a framework to enhance patient rehabilitation adherence by manipulating the 4 experiences to increase self-efficacy in completing therapeutic tasks. And the therapist can do this by engaging in further questioning to determine which of the 4 types of self-efficacy experiences to focus on to increase self-efficacy to manage an upper extremity dysfunction. So for example, let's consider a 45-year-old high school teacher experiencing carpal tunnel syndrome, a condition causing numbness, tingling, pain, and weakness in her dominant hand. This affects her ability to perform tasks like writing on a smartboard, typing on a keyboard, which are essential for her job duties. So since developing this condition, she has experienced heightened distress, evidenced by increased upper extremity muscle tension. She is now concerned about the increasing limitations and feels unsure about effectively managing her symptoms. It can be assumed that the client is experiencing heightened physiological and emotional states in managing her upper extremity condition. The therapist can use the next opportunity in therapy to educate the client about her bodily responses due to distress, such as muscle tension and increased heart rate, and then to let her know or educate her how these internal sensations can affect the healing process. Subsequently, the therapist can encourage the client to consciously explore bodily sensations like muscle tension, elevated heart rate, and then provide her with a modified therapeutic activity incorporating the breath to movement exercises to reduce elevated heart rate. This will demonstrate to the client that she herself can manage her symptoms and decrease her emotional arousal by continuing the therapeutic activities. This approach can help increase self-efficacy while encouraging self-awareness, self-regulation, and acceptance of bodily limitations that can transcend into everyday tasks and occupations outside of therapy.